Thank you all for being here. For those of you who I don't know, I'm Sandro Galea. I have the privilege of being Dean of the School of Public Health at Boston University, and this is one of our Dean seminars. We actually call these Dean seminars on contemporary public health issues, because we try to arrange them around topics that we actually think are emerging and ever-growing in importance. So today we have a topic which is a little bit unusual for us, but in many respects it actually should not be unusual. It should be much more common. We're talking about public-private collaborations, and the title is A Path to Sustainable, Affordable, Equitable, and Patient-Centric Healthcare. And in many respects in public health, we often talk about how our role is to create social, environmental, cultural conditions that create health. And historically in public health, within that remit, we have seldom talked about the private sector, which is really a pity because, of course, as we all know, our lives are touched by the private sector in enormous ways every single day. So for us to think that we can actually create these kind of conditions without dealing with the private sector strikes me as folly. So we have a speaker who we invited who we actually think is really better equipped than most to speak about this. Our speaker, Arnaud Barnard, is somebody who has spent his entire career working in different aspects of the private sector. He has an MBA from HEC, and he spent many decades of his life in multinational organizations like Baxter and Philips Healthcare before 4 years ago turning his career to the World Economic Forum. As a member of the Executive Committee of the World Economic Forum, Arnaud has launched defining public-private coalitions in fields that range from epidemic preparedness, vaccines, antibiotic prevention, value-based healthcare, precision medicine, access to primary care, healthcare IT, et cetera, to name a few. And on all these matters, he actually has the position of both convening a variety of groups from the academic world, from the private sector world, but also trying to develop projects that nudge systems, private and public, towards performing better and towards producing better health. So I've really been enjoying my conversations with Arnaud, who I actually think genuinely approaches things from a perspective that says population-based approaches can transform global health as long as the right players are at the table. So I'm really looking forward to hearing Arnaud and learning from him. Thank you for joining us. Welcome.
Thank you very much, Sandro. I mean, you're too kind. I had the privilege to meet with the dean of your famous university in the School of Public Health. We had a chance to meet in New York. When was that? 6 months ago, something like that. And this is when the idea came up to actually work together in discussing how public-private partnerships can actually improve the state of the world when it comes to health and healthcare. And this is where I'd like to start my pitch, in a way. I've been myself in the industry for the best part of my career. I've been working within the pharmaceutical industry, spent a few years within Pfizer and Pharmacia, and then joined medical equipment providers that are serving large healthcare delivery networks, hospitals. That's where I joined Baxter Pharmaceuticals, very active in the field of infusion pumps, IV solutions, you name it. And then after a few years at Baxter, actually 5 years at Baxter, I joined Philips for the role of building the home healthcare business. That was an absolute unique opportunity for me, especially because we realized that that business was going to be built in the US to start with. And after a year within the Dutch company, I got the chance to actually migrate to this part of the world, and I stayed in Boston for 10 years, making a number of acquisitions and partnerships, some of them translating into a large business that you may know in Andover, Massachusetts, where the global healthcare business of Philips is still located. And we made acquisitions in the field of home healthcare. We made acquisitions such as Lifeline in Framingham. We made acquisition in the field of respiratory disorders. We acquired a large company by the name of Respironics in Pittsburgh, and on and on and on. And after 10 years, Within Philips, that business was of a size that is decent, I would say, 2 billion in sales, highly profitable and still fast growing. That was my business development days. And then I was approached by the World Economic Forum, and that's about business development in a way, except that you can do that on a much bigger scale and a much neutral fashion. The World Economic Forum is an international organization, but this is the only international organization that is funded by the private sector. So we enjoy the relation with 1,000 of the largest 2,000 companies on earth, a little bit more than 1,000. And our claim of faith is obviously that we convince those guys in Davos every year, but I can tell you there is much more than Davos. Hopefully, even though it's quite a week, I tell you. So in the field of healthcare, that's where my own community is formed of 65 health and healthcare partners. The very large pharmaceutical companies, pretty much all of them, and a number of them being US-based, by the way, from Pfizer, J&J, GSK, you name it, Takeda, Novartis, Sanofi. A lot of them have their own research facilities, by the way, in this part of the world, in the triangle on the other side of the river. So those guys are very important members of my community, over large medical equipment providers such as Medtronic, Philips, Siemens, GE, Thermo Fisher, Illumina are also members of that large community. And a number of very prestigious healthcare delivery networks, two of which actually being based in Boston. Brigham and Women is one of them, and Dana-Farber is another one. And I'm going to have the pleasure to meet those CEOs tomorrow again, because we manage that community with a very, very strong proximity. It's like a family. But other guys, Sloan Kettering is another one, Texas Medical, MD Anderson is another one, just to name a few that are in this part of the world, but increasingly we have Chinese partners, European partners. And as much as this community is actually a community of funding members, they also tend to join the forum because they share our vision and mission that has been the one of the World Economic Forum since 1971, when it was funded, and that is to actually improve the state of the world. So I can tell you with a straight face that we would never undertake a project that would be even close to the one of an industry association. We are not entertaining lobbying discussion of organization that could be close to lobbying interest of the industry. Everything we do is with a goal to actually repair something that is damaged in the context of the way health is distributed and healthcare is delivered. And we do that by convening. So we convene different constituents at the most senior level, and those constituents guide us and select the projects we're going to be running. We decide in Davos what those projects are going to be, and we run those projects with very tight project management structures for a year, and we drive those projects into a number of regional events where we're going to capture the regional dimension to those very problems and create more of that common agenda. And from time to time, from a common agenda, a miracle does happen. And that miracle is the birth of a new coalition. That's really what we're doing. That's very simple. And hopefully, that new coalition, we can launch it in Davos the year after. This is what we do. We are time-bound between two Davos. And frankly speaking, if we can't make a change happen in 1 year with the senior policy makers, ministers of health, heads of states, heads of international organizations, heads of civil society representation or patient associations, and the private sector being involved to bring in their assets and capabilities. If we can't make that change happen in 1 year, well, it's probably that there is a bigger problem. And we have seen again and again that the forum has been a platform to actually improve the situation quite a bit. I think I remember a quote from Peter Pio, the individual that discovered Ebola, as you may know, is also at the London School of Public Health and Tropical Medicine. He said that the first discussions on repricing antiretroviral treatments to combat HIV actually did happen in Davos. A lot can happen when you get people behind closed doors and they leave the room with a commitment to work together. That's where the Global Alliance for Vaccination and Immunization was actually launched in Davos in 1999. As you may know, this particular coalition, in effect launched on the platform of the World Economic Forum, has been raising since its inception close to $10 billion in donations and arguably saved the life of 7 million children. The Global Fund was launched in 2002 in Davos as well. I mean, the Global Fund to combat tuberculosis, malaria, and HIV. And again and again, and 2 years ago, and I will come back to it, we launched another coalition that's called the Coalition for Epidemics, Preparedness, Innovation. We are recognized as an organization that can convene and can reduce the tension between the public sector and the private sector because we are neutral, non-for-profit, and driven by our mission. Now, what this means is that we have always an aim to actually focus on something that is not addressed by others. So we are not a normative body. We work with WHO, but we would never be the one to say too much sugar, too much trans fat. No, that's not for us, okay? We work with the World Bank, but we are never going to release social burns or impact burns. We convene those constituents in projects, and we work with a board of governors that is formed of CEOs of large corporations, but also ministers of health from the Netherlands or the head of NHS in the UK, some heads of civil society organizations such as Joanne Liu from MSF. This balance is interesting because it's not only about the business, it's also about the access. And access is extremely important for everything we do. I want to discuss today how we can apply public-private partnership in 4 areas. Area number 1, value-based healthcare. Area number 2, creating investment models that can improve access in emerging economies. Topic number 3, preparedness to epidemics and pandemics. And finally, I would like to conclude on the role of public and private collaboration in the advancement of precision medicine. And then we can cover many other things as part of the Q&A. But why those 4 themes? Because by way of context, since, like you well know, I think, and I'm going to fly on that topic because I know you probably know even more than I know from your academic background. But we know that the cost of healthcare system are unsustainable. We all know about the monster 7 or 8 trillion being spent annually, corresponding to 11 to 12% of the global GDP, and growing at a pace that has consistently outpaced the pace of the global GDP for the past 60 years, since 1950. So we know about that monster problem. By the way, I like to tell my colleague from the banking industry, this healthcare industry is 3 times the size of the banking industry. So not only it's a monster, it's fast growing, it's uncontrolled, but frankly speaking, when you think about the impact on economies, in spite of all the money spent, we can only deplore that it's not delivering on its promise. Variability of care, which is documented again and again, and I don't know if the 30% is the right number, but at least it's a number. So variability of care costing 30% in waste. Growing pressure on healthcare professionals, shortages of nurses, ridiculous density of medical professionals in emerging economies. Like we know in Nigeria, it's 4 doctors for 10,000 inhabitants to be compared to 34 in Germany. So adding more doctors is not going to change or resolve the problem. I mean, we made that study with the Boston Consulting Group and came to the conclusion that to reach the level of doctors you would have in mature economies in a country like Nigeria would take 300 years. Okay, 300 years. So I think, obviously, we need to find new ways, and the lack of healthcare professionals is also something that we see happening in mature economies. I'm talking about nurses, but you know, shortage of digital pathologists, shortage of mental health workers, shortage of radiologists. So this is a system that's not working well, but in the meantime also does not provide for universal healthcare access, and that's where the equity issue lies, with 2 billion on the planet not having access to healthcare. Now, in that context, precision medicine. Okay, so we are going to individualize treatments and cure people we could not cure before. But what for the emerging economies? Is this even going to increase the degree of inequity? Is precision medicine going to be a medicine for the rich? Or is this something that can help leapfrog existing healthcare system and be a solution to the poor? So that's the context. That's the context. We started, and I'm moving where it can be applied to value-based healthcare. We started 2 years ago a program, I think, with your friends from the Harvard School of Public Health, and Michael Porter was involved, and trying to see what we can do, because those books are very nice, but how do they translate in practice? Okay, how do they translate in practice? I think again and again and again we see the macro demonstration of return on investment not translating in individual micro models, be it at community level or at the level of healthcare delivery networks. And that's where we can catalyze partnerships. The partnerships are not global only level partnerships. We must secure, when we think about this integrated practice unit theory, that is nice, but it requires a degree of complexity in the implementation that in the context of value-based healthcare, for us at the forum to even launch that coalition in Atlanta, to actually target chronic heart failure patient. It took us to assemble a coalition of 40 different partners, ranging from healthcare delivery networks, insurers, payers, patient associations, not even to talk about the role of the city and the mayor's office. Those things are very difficult to implement because we can talk about the new payment models, how the risk accrues to some participants as opposed to others. The truth is that incentives are fundamentally misaligned, and it takes immense courage, political courage, or business courage to actually participate in a project that has the role to realign those incentives. And that's not going to happen without policymakers and private sectors working in tandem. I like to say value-based healthcare and incentives, and I like to take the example of dialysis. What is your incentive if you are a company like Davita or Fresenius to actually promote home health dialysis that is absolutely clinically proven to be the right solutions for patients when your customers, nephrologists, actually are the physical owners of dialysis centers and they accommodate patients 3 times a week in the only ways they have to actually recoup the investment they made in hemodialysis machines? What is going to be your incentives? It's not going to happen unless payment models are going to provide for a holistic, continuous treatment of the patients from peritoneal dialysis to home health dialysis, in-center dialysis, renal transplant. But the number of constituents that can look into that care pathway is more than one individual company. And the payer needs to be part of that discussion and provide for rewards and incentives that are going to reward the different participants in that care chain, a little bit like we have the discussion in precision medicine. What is the value of a diagnostics as opposed to an immunotherapy treatment that is targeted to an individual? Diagnosis is very cheap, but if you don't have it, forget the immunotherapy treatment. So we started to look into it, and before to start boiling the ocean, we decided let's do something simple. Let's do something simple. And this is precisely what we will do in Toronto in the field of diabetes treatment, and that what we will do also in Singapore with a third pilot, because we want to prove that the moment in a network you exchange data and you define outcome standards, you create the tools to actually benchmark between individual healthcare delivery networks. And the moment you disseminate that knowledge in the network and then beyond the network with patients, you will see that, like in any industry, measurement of variability will create the knowledge platform to actually adopt the best practices, and in turn, that variability will reduce, which will ultimately benefit patients but also reduce the cost. It's no rocket science. That's called Six Sigma, that's called fishbone analysis in the industry. That's applied everywhere, in every industry. And there is absolutely no reason why it cannot be implemented. And we want to prove that in Atlanta, where we actually target a 30% mortality reduction in 5 years, and we'll do that also in Toronto, because think about that. The transplant study run by UCLA, monitoring 240 US renal transplant centers from 1988 to 2006, has proven that by monitoring, implementing dashboards, the outcome variability could reduce from 19% to 6%. But also the average was increasing, average outcome. Outcome being measured as a function of survival rate after 1 year. So, you know, we have to do it. And our whole goal as a convening platform is use those platforms, use those pilots to actually become the backbone set of tools to actually create that broader platform of value-based healthcare early adopters, with ultimately even possibly the goal to launch a coalition that will be independent from the forum and will ultimately become an accreditation mechanism for value-based healthcare. So that's one example of what we can do. And frankly speaking, I see no other way but public-private partnership. No other way. Because look into what's happening in Atlanta. That's irrespectively of any discussion on Affordable Care Act, no Affordable Care Act, Obamacare, no Obamacare. No, you can do it. If you put the right constituents in the network and they agree to share data, variability will reduce, outcome will improve, and cost will drop. This is not common sense, plain common sense. I think from time to time, and I immensely respect the higher level policy discussions, but from time to time we just have to do the right things. And don't get me wrong, universal healthcare coverage is to me a human right. Period. It needs to happen. But there are things that we can do absent of the highest level political discussions, just by convening the guys that have authority and can make the change happen. Now, another example, topic number 2. Emerging economies' health systems. It has been evidenced that if we want to reach the universal health coverage 2030 goal, or said otherwise, SDG 3.4, it would take an additional global spending in the early years of $134 billion US dollars, increasing to $371 billion in the out years. Those are interesting numbers because you have to think that the official development assistance money in total last year was $140 billion, and that's way beyond healthcare. It takes infrastructure, it takes climate, it takes everything. So the short message is, whom is going to put this investment? Who is going to provide that money? No, that's not going to, forget about cooperation money. It's not going to happen. It's not going to be enough. Never. It's never going to be enough. So the money has to come from 1% public health spending in India. Private sector is one of the only ways when they invest in those emerging economies is one of the only ways whereby universal healthcare coverage will be accomplished. That's my absolute, genuine belief. But we need to make sure that we create the models for the private sector to invest. Because, again, it's a question of translating the macro-level return into a micro-level business case, which is extremely difficult. Because in 2013, the Lancet Commission estimated that between 2000 and 2011, about 24% of the growth in full income in low-income and middle-income countries resulted from the value of additional life years gained from improved health, 24%. So return on investment, no discussion. We had that study in 2011 showing that the cost of NCDs was 47 trillion between the year 2012 to 2030. So addressing those issues have obviously an enormous economic return at the macro level. But no one is doing macro investments. Investment happen at the micro level. A macro investment doesn't exist. So what does it take to make a micro investment? It needs to create, a little bit like in Atlanta, a model with partners along the care pathway that, for instance, is going to be rewarded to invest into primary care. Now, Abraj, one of the large private equity investors that is investing in Africa and in India, is acquiring Tier 3 facility hospitals. That's good news. But guess what? If there is no private primary care system in place, I mean, those hospitals are going to remain empty anyway because you will not diagnose those patients. So why not construct a way whereby Abraj would be incentivized to create community life centers primary care units, which in turn would create preferred pathway for them to actually benefit from those patients as they get admitted in those hospitals. And then you leverage technology, obviously. Telehealth, mobile hubs, remote diagnostics centers. That's doable. Now, interestingly, you see some companies doing it. When GE is investing close to 500 million, I think, to build 97 radiology units in Kenya, GE is not acting out of corporate social responsibility. This is because they understand that Kenya is a country that had a population of 8 million in 1960, 44 million today, and will reach a population level of 85 million in 2050. And in the meantime, from 2009 to 2016, the GDP in Kenya has increased by a number of 25%. So one day, there will be a return. And that's where they're investing in Kenya. Now, if you are in the private company world, and you are GE, you can decide that you are going to build an electric grid in South Africa, or you're going to invest in 97 radiology centers in Kenya. You know, that's a cold decision. It's a business case. The finance guy is going to be on top of it. It's going to be a return on investment based on risks. You can model all those things. Can you? No, you can't when it comes to healthcare. It's precisely the problem. Because to be able to build a 20-year business case, as you invest in an emerging economy, you need to have the predictability of a regulatory system, a political system, a pricing system, a deliberate intent to invest in training doctors that is not necessarily present. But when you have that deal with the policymakers and you're going to get the predictability, then you will invest in healthcare because the return will be higher than to invest in an electric grid in South Africa. So that's public-private partnership, that's give and take. Nations and governments need to ensure that is what is most valued by the business, i.e. predictability, is being offered as part of the ecosystem to invest. And that's where we will see more and more examples like Abraj, examples like GE, examples like the Investment Fund for Health in Africa, invest again and again. I think that's what's going to attract VCs. Because at the end of the day, the return will be high. It needs to be translated at a micro level, meaning individual business cases that are predictable. And that takes stable regulatory frameworks, pricing, tendering processes, re-tendering processes that are clear and transparent, because that's going to actually de-risk the business case. Alternative, well, or complement, there is a strong argument to be made that actually when the risk is still too high, actually the funding of international organizations such as the IFC, for instance, would be better used to serve as a guarantee to individual micro-investment models as opposed to direct investments. Because the IFC will never have enough money. But the balance sheet of the World Bank is very strong. And that's a probability discussion. But if 1 in 10 is going to fail, that's okay for the World Bank. So using those international institutions as guarantors, as opposed to direct investors, using the strength of the balance sheet to actually catalyze a number of the micro-investment is actually a very good idea. And that's where we will work more and more in those types of projects. We're actually launching a primary care coalition in the state of Kulu in India that is precisely built in that fashion with the bank, with the World Bank. So that's where increasing access can absolutely leverage the public-private partnerships. It's not an option. It has to happen. Now, I would like to move into my third theme, and that's epidemics, readiness and preparedness, because this one is a no-brainer. During the Ebola crisis, we counted $500 million in private sector investments by way of providing, treatment unit, protection unit, gloves, direct donations to international organizations, and then we have seen pharmaceutical companies, J&J, GSK, MSD, Merck, actually splashing hundreds of millions to try and get a vaccine in 2 years. Hopefully, they had a few candidates on the shelves because they had their own cooperation with Bavarian Nordisk in the case of J&J, and Merck had their own particular relation with the Canadian research institutions like the Canadian NIH. So they were candidates. But all of that has been done in a totally chaotic manner. And chaotic means, if you talk to the J&J heads of research, they had to stop everything pretty much. He would even tell you that they received a call from President Obama and said, listen, you have to build that, you have to bring that vaccines to market. And then you stop everything else, which has a commercial value, predictability. Predictability. Public-private partnership can serve as a way to organize a predictability for the business. If you know that you're going to be, why not do that in a coalition? Why not do that in a more structured fashion? That's where we started in 2016, the discussion on the Coalition for Epidemics, Preparedness, Innovation. We got the 6 largest vaccines manufacturers, J&J, MSD, Sanofi, Takeda, GSK, and we got them in Davos. 6 CEOs were there, ministers of health from a number of those nations were also in the room. Large donating countries, the Gates Foundation, the Wellcome Trust, and we left the room saying, okay, listen, we're going to work together. And we're going to work to support the WHO blueprint that has identified 10 pathogens that have no vaccine, and frankly speaking, will never see any commercial incentive for anyone to develop a vaccine. Because whom in their right mind in the private sector would even think about bringing to market an Ebola vaccine? For vaccinating what? 20,000, a population of 20 or 50 or 50,000 in West Africa? I mean, you'd never get a vaccine. I think that's not possible. I think a vaccine costs 1.5 billion to innovate. I mean, what is going to be the cost of a dose of those vaccines for 50,000? I mean, it's never going to work. And no one can pay. So we launched that coalition after a year of intense discussions where everybody has been giving a bit. I need to say private sector gave it for cost, not making any profit, though based on that business case, donators became generous. And we raised the 800 million, and that coalition was launched in 2017 in Davos, and we keep seeing more nations join that particular coalition. We started with Norway, Germany, Japan, India. Now Canada is joining, Belgium, and I'm still in the board of this coalition, CEPI, and we signed our first development agreement with a Belgian biotech firm, and I think we're going to see for Lassa fever, and I think we will see more of them, and those coalitions can be triggered as you convene public and private, and then everybody gives a bit. But think about that. I mean, when you are in the room and you are the CEO of Pfizer or the CEO of GSK, are you going to leave that room saying, I'm not in? I think that's where you leverage that platform of the World Economic Forum. There is a little bit of give and take. But frankly speaking, in those discussions, I mean, it's unacceptable from a branding image standpoint to actually leave the room and say, I'm not in. And you need to maintain that Davos continuum and pressure so that no one is going to leave the partnership before another year, so that you can launch it in Davos and that's done. But you also need to respect values of access and equity and accept that some of those discussions are going to be difficult because there is no commercial margin now. And the price has to be a one that's going to protect affordability and access. So that's where you create those natural tensions as a way to trigger those partnerships. But the reward is immense if we can manage to put more of those partnerships in motion. Because, like it has been documented by the World Bank, an average epidemics that would be airborne would cost the planet $570 billion, or 0.7% of the global GDP. So, you know, what is 800 million or 1 billion or 1.5 billion if that's going to protect the world from a risk of that kind? And the same applies to the field of antimicrobial resistance, where we know that when nothing is going to be done, 10 million will die on the planet in the year 2050 for resistance to existing antibiotics. The pipeline of our new antibiotics is very shallow. Companies are leaving the space, and we're talking about a cost that is in aggregate and cumulated could range as a massive amount of 50 trillion by 2050, and maybe it's a matter of having a couple of, maybe, I don't know, 2, 3, 5 billion to innovate in that space, and creating the conditions we discussed CARB-X. And CARB-X is a push mechanism. So it's funding early stage research. But the problem is that when you get your target drug to phase 1, that's where CARB-X stops to play in, and that's where the commercial incentives need to happen, and you need a complement of pull mechanisms to get those antibiotics to the point they become licensed products. And those pull mechanisms have been innovated. Some of them are in the GAIN Act as a model being discussed in the US. Some of them are about extending priority review, reducing priority review vouchers on other drugs, extending IP protection to other drugs. I think it needs to be a very balanced discussion, because you don't want that it benefits too much the pharmaceutical industry, but on the other end, you need to innovate those pull mechanisms, otherwise nothing will happen. So it's a type of discussion à la CEPI, Coalition for Epidemics, Preparedness, Innovation, where actually everybody needs to give a bit. And that's a public-private debate. What is a public-private debate is also what's happening when we start using this particular vaccine and it's not licensed yet. And everybody wants to do that because, you know, there is sufficient efficacy proven as a result of a phase 2 progress in the pipeline, so that actually you know that you've got very high likelihood of saving the lives of healthcare workers if you organize the right ring vaccination trials. You may even protect communities. But it's not licensed. So the manufacturer would be on the hook for an incident or an accident. And the question of the liability needs to be a discussion between the manufacturer and the receiving nations, or maybe the World Bank, by way of leveraging the Pandemics Emergency Fund. And all those instruments need to be orchestrated in a way where public-private discussion, if it's not going to happen, will result into the same mess as we had the last time. So that's for epidemics and pandemics. I think we could also discuss the role of the travel and tourism industry, of the airliners, of the supply chain companies, of the ones that are capable of tracking populations, people that are operating GSM networks. You know, those capabilities that are not even in the field of healthcare can be super helpful in the context of organizing a better response, because those companies that have populations of workers in those nations that are affected, they have assets. They have assets and capabilities that can be mobilized. It needs to be orchestrated. They have assets, they have cars, they have trucks, they have phones, they have networks. And those assets can be mobilized. It's a question of enabling the right level of dialogue so that those networks can be established informally in advance of a crisis. That means that if the public and private are not going to cooperate and work together, I mean, that's another loss of an opportunity. And I would like to go into my last topic, that is precision medicine. There is one thing that possibly could happen, that is that everything that is coming from science and research and that is so exciting at this point in time, could well not benefit patients, or benefit patients within a time frame that is, frankly speaking, not acceptable, if some issues are not to be resolved. And I'm thinking about the way we generate clinical evidence, for instance, for precision medicine. The traditional way of generating clinical evidence by way of randomized clinical trials is simply not working in the context of small cohort of populations, be it because we're talking about rare disease or we're talking about patients that are going to respond to a particular drug because they have a certain genomics mutations. But frankly speaking, how are you going to find those patients and organize those large-scale randomized clinical trials? I think the generation of clinical evidence and economic evidence needs to be rethought, like we have seen in the context also on a parallel domain like Hep C drugs. Yeah, okay, what is the value of curing a patient? What is the value of the new drugs being innovated by Gilead or Novartis in the field of immunotherapies? The evidence of the clinical evidence is one thing, and obviously the topic of translating that clinical evidence into clinical practice is also another thing. The regulatory framework to actually enable those drugs to actually reach the patient need to be re-evaluated in the context of a public-private dialogue. And obviously the pricing and reimbursement pathways need to be also explored. Because at this point in time, I think there is very little coordination between health technology assessments organizations and the regulators, and even the pharmacoeconomics senior managers that are working in those large-scale cooperations. So that is all a little bit disjointed, and you end up with $1,000 a day for a given drug, which by coincidence is equivalent to the price of a transplant replacement. That's a coincidence, I assume. But that's not the way. That's obviously not the way it should be. There is an element of sharing risk. What if there is a relapse? Is this possible that the manufacturer would be on the hook for the benefit that has been lost to the society? What if there is a reoccurrence of a disease because of a behavior, because of the behavior of the patient itself? Is this fair that the insurer would pay a second time? And on and on. But at the end, it's also about data sharing, because a lot of those enablers to the different discussions is about a common set of data, and maybe having forcing the regulatory frameworks to go into basket trials where actually exchange would be enforced between manufacturers, including in the sharing of data for failed trials, could actually improve in a big way the quality of those discussions, and the pricing and reimbursement pathways could be discussed in more solid ground. Now, there is an education to doctors, because 7 in 10 doctors in this nation still believe they should own the data. It doesn't belong to the patient. So I think there is an element of an education that's certainly an area where the public sector needs to take a role. But actually, if you look into even sharing data across individual states, requires some form of accreditation in the US, not even to talk about my home country in Switzerland, where actually you've got 17 regions and they don't allow cross-border flow of data in a country that is only 10 million inhabitants. So I think there is a responsibility of the policymakers to actually allow for data exchange, and then the knowledge needs to come also, because obviously there is privacy matters. But frankly speaking, why is that other industries can fix that with blockchain, and we can't do that in healthcare? So I think that's where suddenly you see an influx of capabilities and assets from the private sector that is required for this discussion to be a one with an outcome, and involving the patients' association in that discussion can make it even more relevant. So precision medicine is a field where it's probably the most difficult one. It's one of the most difficult ones because it takes to innovate new models to benefit patients in the context of a convergence of technologies from the fourth industrial revolution. And that's not something that is trivial in the mind of people, because people tend to think robotics, they tend to think genomics, they tend to think artificial intelligence in relative silos, and the regulatory frameworks are organized by those individual silos. And the policy decision-making framework are organized by those individual silos. So I think that's where at the World Economic Forum we're trying to create precision medicine initiative in various centers for the fourth industrial revolution. We have one in San Francisco. We have one in in China. We'll have one in Japan. And what we do is actually bring secondees from governments and secondees from the industries, and they mandated by the government to actually work together, pilot things, make recommendations, and possibly get to actually educate the decision makers in framing better policies. But it takes pilots, testing, experiments. And that's something that, again, ranges from macro to micro. It's always the same thing. It's macro to micro. I mean, you need to translate those bold ideas into individual pilots that can be scaled up, or individual business models that create the return to the private sector in a more predictable fashion, or actually realign those incentives like we are doing in Atlanta, we want to do in Toronto. I think that's what we're trying to do at the World Economic Forum. It's really ranging from macro to micro, make catalyze partnerships. Thank you very much.
Is this on? Thank you. That was terrific. It's really, certainly from my perspective, very helpful to hear a perspective that comes from a world which really, as I said at the introduction, doesn't intersect with our world as much as it should. But everything you said sounded great. So can you talk about problems? Can you talk about what are the challenges? Because you made it all sound possible. Can you talk us talk us a little bit about the impossible?
I mean, we fail. Yeah, you know, we fail a lot. I can tell you about. I can tell you that in general we fail when we can't establish the trust, and that's where we fail. I remember a Minister of Health. I'm not going to quote the country, but he said, "Well, all of that is good. But I know what PPP means. It's profit, profit, profit." And then starting to have a discussion under those terms was becoming something that was in effect almost uninteresting, because the only thing he would be focused about was to outsource laundry services for these hospitals. It's not transformative. I mean, It's not about discovering new gain-sharing, risk-sharing models in an attempt to actually outprove outcomes. It was a pure outsourcing type of model. Outsourcing is not public-private partnership. Outsourcing exists. It's done by tender, and that's fine. It needs to exist, but it's not my view of a public-private partnership. So in many instances, we have had that go nowhere discussion where you don't manage, you don't pass the first gate, and that's highly frustrating. But I need to realize that it happens, and that's painful. But then we need to move on and continue to make an impact on another space, as frustrated as it can be. That's unfortunately the case. I think we had also good experiments where, it works fine, but then you can't scale up. You don't manage. I think it's too difficult. I think we have been seeing community life centers in the 6-county, as part of the 6-county initiative together with USAID in Kenya. Those community life centers individually are very, very powerful, and they are not very costly. But still, I mean, you need 200K, and you need a little bit of this and that, but you would need 1,500 of them, and that's very difficult to actually get one private sector company make this investment alone, and to create that coalition is more difficult. So scaling up has been also, in some instances, a scale up of a particular micro model into something larger has been difficult.
Hey, thank you very much for that. I learned a lot from what you were saying. But let me ask you something different, which is at Davos, when you guys are meeting there, does anyone ever turn around and say, these are common everyday problems. We really have to think bigger on this planet. The planet has major problems like climate change, like new genomics, like big data, if you will, artificial intelligence. And if we don't get involved in those, they're just going to happen, and we're going to just have problems with them in the future that we may not be able to handle. So yes, these are fine. These are nice projects, but they're not very ambitious, I would say, for a group that says it's a world leaders, both private and public.
Well, I think I think they have a degree of ambition. I think they have a high degree of ambition. I think the ones that have been the most successful actually stand a chance to change a big problem that no one was able to fix before. I'm thinking about innovation in vaccines for ignored pathogens. I think I've seen I've seen no movement at all for the past 4 years until we had that first discussion in Davos, and we landed CEPI a year after. I think models like the ones of Gavi has been super innovative in the first place. And I would tend to think that 7 million lives being saved is not a bad outcome.
No, that's a good one. I would have included vaccines.
Yeah, well, the Global Fund was kind of a good one as well. What I mean is that, don't get me wrong, I think you're right. I think we need to have the broader discussions. We had some of them, by the way. I think we need to avoid that we build the biotech genomics framework the same way we built the internet, for instance. That's a good dialogue to be had. We had those dialogues because, yes, I think we need to make that with rules and regulations that are going to protect us against the backdrops from synthetic biology. And those are the bigger discussions that are societal in nature and don't translate to my demonstration before. They don't translate into micro-level discussions. Those large debates need to happen at the macro level, and they do involve policymakers at the highest level and beyond health. Beyond health, I fully concur. Now, we're trying to have that. I was trying to propose today the point that public-private discussions maybe is a better candidate for micro-level initiatives, when what you may have in mind is probably more in the remit of cross-country policymakers' agreements that take courage, but frankly speaking, from time to time, hard regulations as well. It cannot be soft in some of those territories. Soft regulations is a little bit worrying.
Hello. Hello. Good afternoon. I have two questions. So the first one is on what you were talking earlier on, instead of having these outsourcing relationships, more on the sustainable aspect. How could we establish those collaborations with the private for-profit sector and the schools of public health? What would be our proactive approach to that? Do we have to go to Davos to be part of the discussion? What would be your recommendation, and what would be the challenges for that? And the second question is on the shared value model and the theory of business, and which is interesting today in the growing attention to CSR. And I would like to know what is your view of, are there situations where shared value is more an illusion and business values can be contrary to societal values?
Yeah, I think, I think I did not talk about corporate social responsibility investments because I think they will be insufficient, but don't get me wrong, I value them. And I think I think the one trap would be if corporate social responsibility investment would be done out of philanthropy to the point where we are less professional in a way. I think that if you look into the way the Gates Foundation or the Wellcome Trust are investing, that's highly professional. And I would argue that corporate social responsibilities investment should be done in a way where we can leverage novel solutions such as impact bonds or these types of things. It's not a free ride. It's not free money. It's going to be donated, but there is no excuse for making a wrong investment if the investment can be having more impact in, it's still limited resources. But I see that a number of those large corporations, they have their own foundations. But that's tiny, yeah? That's still very, very small. I think Novartis Access Foundation, the Pfizer Foundation, that's not going to. It's good, but it's not going to transform. I don't think it's going to transform healthcare systems. Not an excuse to not use the money in the right fashion. To your point. The first point, I think, the more I think about that, I think there is immense value. I think public-private partnership is very difficult to organize if people speak two very different languages. And that's what I did find tough when I joined the World Economic Forum, because I was hardcore private sector. That was my life. I've been 20 years in the industry. I speak payback, return on investment, risk premium, risk factors, bonds. That's my language. And I did find that there's no way. I mean, try and get to the WHO with those arguments or with those ammunitions. You're going to be killed before you pass the door. And I think there is immense value to try and learn a little bit of the language of the other side, if I may call that two sides. It should not be two sides. But as long as there will be a little bit of two sides, I think there is immense benefit to even understand how decisions are being made in the private sector, and for private sector to understand how decisions are being made in the public sectors. I mean, the way the WHO is functioning and the role of member states, the role of diplomacy, how relations between nations do happen, the role of this individual organization, why IFC, why World Bank, what is their roles? I mean, don't knock randomly if you are private sector at any door. I mean, you want to help on Ebola, and so this morning you can call the Red Cross, and next week you call MSF. I mean, no. I think those private sector organizations, they need to also understand the policy, the health policy ecosystem in a more savvy manner. I think it's a little bit. I think it's probably a good theme to build something in common there, even probably maybe even from an academic angle.
Hi. This was really interesting. Thank you for coming. I have two quick questions. You can answer either or both. One is, how does a public-private partnership overcome a regime change or a party change or a new president or a new health minister? And two is, can you talk about corruption and kind of the checks and balances for effective public-private partnerships?
I think to your first point, I think, it has been only 4 years. Interestingly, there is a study showing that amongst all ministers, the Minister of Health is the fastest rotating animal. So I don't know why this is the case, but we had only in the past 4 years in the G7 nations, I think all the ministers have changed, and governments have changed. They've changed in Italy. They changed in the Netherlands. They changed in the US. It's changed in France. I mean, it's changed everywhere. I mean, Germany is changing now. Party lines and so on. I think we're working a lot with the level that stays, generally speaking. So if you take Canada, yes, the ministers may have changed twice, but the deputy minister, that is not a political appointee, has been the person we have been in contact for many years. So I think with agencies and secretariats, I think you need to build that deep relation that you're building with the private sector, because the same happened in the private sector, by the way. If we have only connections with the CEO, the moment he's going to be replaced, we're going to lose a partner. So I think this is the same dynamic. And then there is the theme of corruption, which is obviously a tough one for our industry, because we are one of the most exposed industry. Because we are an industry where the one to benefit from the product or the solution is not paying, so that's okay. And the one that actually pays on the budget, and those incentives are for volumes. So, and frankly speaking, from time to time, you've got distributors in the middle that further create that lack of transparency in the pricing. And we have seen companies being exposed to corruptions in our field. At the World Economic Forum, we've got a partnership we've got a community of companies that is called the Partnership Against Corruption Initiative, and we have a number of our partners join that. I think there is a genuine concern. I think there is a genuine concern. We've seen concerns in China with GSK. We've seen concerns with Novartis. The corruption is taken very, very seriously now. I can tell you, for us, as we make our due diligence on partners, we're also very rigorous. So when this has happened in the past, we have stopped our relation. That's part of our guidelines and ethics.
Victor,